Deficiency affects gene expression and epithelial integrity. And what is the biochemical test to confirm vitamin A deficiency? थ्योरी में बेटा पढ़ा होगा पूरा, एंड आई होप आप सबको याद होना चाहिए बेटा. ठीक है. बायोकेमिकल रोल इन विजन बेटा देखो, विटामिन ए रेटिनॉल इज ऑक्सीडाइज्ड टू रेटिनल which form chromophore 11 cis retinal. The answer to the first question. 11 cis retinal binds to opsin to form rhodopsin, a crucial pigment in rod cells. In rod cells. पूरा वर्ल्ड विजुअल साइकिल बेटा थ्योरी में हुआ है ना, वहीं से आ रहा है, ये कुछ नया नहीं है. Upon exposure to light, 11 cis retinal isomerizes to all trans retinal. ठीक है, cis trans समझते हो ना, ये वही है. Leading to activation of phototransduction cascade. Cascade पता? Deficiency impairs rhodopsin regeneration, leading to night blindness. Answer ये वाली लाइन है, लिख लीजिए सब. In deficiency, it impairs rhodopsin regeneration, causing night blindness. Now, structure and function of rhodopsin. Rhodopsin consists of opsin, a G protein coupled receptor, and 11 cis retinal. क्या होता है? It is a G protein coupled receptor and 11 cis retinal. Light absorption converts 11 cis retinal to all trans retinal, activating G protein transducer. ठीक है. This cascade decreases cGMP levels, closing sodium channels and causing hyperpolarization in rod cells. ठीक है, causing hyperpolarization in rod cells. ग्राफ में दादा वो बंद कर देना. हम लोग एक्शन पोटेंशियल का ग्राफ में देखता है ना, ऐसे पूरा नीचे आता है, वहाँ पे एक हाइपर पोलराइजेशन का सेगमेंट भी होता है बेटा, ये वही हो रहा है. आगे देखो, कन्वर्जन ऑफ बीटा कैरोटीन टू रेटिनॉल. बीटा कैरोटीन इज 15. ठीक है, 15. Dioxygenase in intestinal mucosa increase beta carotene to 2 molecules of retinol. Okay, retinol is reduced to retinol by retinaldehyde reductase using NADPH. Once again, NADPH का इस्तेमाल हो रहा है बेटा रिडक्शन में. Retinol binds to retinol binding protein for transport in plasma. ब्लड भी कह सकता है. Then effects on gene expression and epithelial integrity. Effects on gene expression and epithelial integrity. अगला क्वेश्चन जो था, retinoic acid, the active metabolite of vitamin A, binds to retinoic acid receptors and retinoid X receptors. तो दो receptors. These receptors regulate gene involvement in cell differentiation, keratinization, and immune function. Deficiency leads to squamous metaplasia of epithelial cells, causing dry conjunctiva, xerophthalmia, and keratomalacia. ठीक है, तो इस वजह से बेटा स्किन डिसऑर्डर्स हो रहे हैं. डन. छोड़ो, इतना आपके लिए रिक्वायर्ड नहीं बेटा. इट इज जस्ट अ केमिकल डिनोमिनेशन. जब स्ट्रक्चर देखेंगे तो उसमें पता चलेगा. Now, biochemical test for diagnosis बेटा. Serum retinol level किसका? Retinol. किसका level? Retinol. When it is less than 0.35 micromole per liter suggests deficiency. Dark adaptation test to assess visual function and conjunctival impression cytology shows keratinized epithelial cell. लाइट एडेप्टेशन, डार्क एडेप्टेशन, आई होप सबको पता होना चाहिए क्या होता है, तो बेटा उसी का टेस्ट होता है. चलिए अगला केस देखते हैं. A 60-year-old female with chronic pancreatitis presents with night blindness, dry skin, and recurrent infections. Lab test reveals steatorrhea with low serum vitamin A levels. Now, the questions. Why is fat malabsorption associated with vitamin A deficiency? Second question. Describe the absorption and transport mechanism of vitamin A. How does chronic pancreatitis affect vitamin A metabolism? Next, what are the storage and mobilization mechanism of vitamin A in the liver? And last, how would you biochemically manage this patient's deficiency? ठीक है, क्या डायग्नोसिस है? सिम्टम्स पढ़ो, डायग्नोसिस बनाओ. अच्छा ठीक है, आगे देखते हैं. Now, fat malabsorption and vitamin A deficiency. Vitamin A is lipophilic, requiring bile salts and pancreatic lipase for absorption. Steatorrhea leads to impaired micelle formation and reduced vitamin A uptake. Okay? Steatorrhea में क्या होगा बेटा? There is impaired micelle formation and reduced vitamin A uptake. लिखते जाइए. Then absorption and transport of vitamin A. Absorption and transport of vitamin A. Retinol is absorbed in the duodenum. Esterified to retinol esters and incorporated into chylomicrons. Chylomicrons transport retinol esters to liver via lymphatic system. In plasma, retinol binds to RBP and transthyretin for systemic transport. ठीक है, तो बेटा ये इसका मैकेनिज्म है, कैसे ड्यूडेनम से एब्जॉर्ब होता है, कैसे लिम्फेटिक सिस्टम में आता है और वापस सिस्टेमिक सर्कुलेशन में कैसे जाता है. ठीक है, दिस इज इट्स एब्जॉर्प्शन मैकेनिज्म via chylomicrons, then RBP, and then after that transthyretin. Okay, for systemic transport. चलिए नेक्स्ट क्वेश्चन देखना बेटा. फर्स्ट वन इज बेटा फैट malabsorption, vitamin A deficiency, और दूसरा है बेटा absorption and transport of vitamin A. Effects of chronic pancreatitis. Pancreatic lipase deficiency leads to incomplete hydrolysis of retinol esters. Malabsorption results in hepatic vitamin A depletion and defective rhodopsin formation. Malabsorption, बल्कि सबसे पहले देखें incomplete hydrolysis, malabsorption, depletion, and after that night blindness. Total cascade. Then storage and mobilization from liver. कैसे स्टोर हो रहा है, कैसे मोबिलाइज हो रहा है? Stored as retinol esters and hepatic stellate cells. Mobilized via hydrolysis by retinol ester hydrolase when needed. And retinol binds RBP and is secreted into circulation. Okay? क्या हुआ आदिल, डाउट है कुछ? कौन सा? लाइपेज बेटा हाइड्रोलाइसिस होगा. लाइपेज हाइड्रोलाइजेस फैट्स. लाइपेज किस पे एक्ट करेगा बेटा, सोचो. क्या बाइल क्या No, that is not transportation बेटा, that is effect of chronic pancreatitis. Transport कहाँ गया? Transport यहाँ था. Mere transport. This is effect of chronic pancreatitis. Mobilized via hydrolysis by retinol ester hydrolase when needed. Retinol binds RBP and is secreted into circulation. Okay. Then what is the biochemical management of this case? It is vitamin A deficiency due to क्या था केस में, देखो पेरेंटल विटामिन ए सप्लीमेंटेशन, इंट्रामस्कुलर रेटिनाइल पाल्मिटेट, कैसे देंगे, इंट्रामस्कुलर रेटिनाइल पाल्मिटेट. Then pancreatic enzyme replacement therapy to aid absorption, and fat-soluble vitamin supplementation with dietary modification. ये इसकी biochemical management है. Okay, biochemical management. देखिए what is the effect of chronic pancreatitis? Incomplete hydrolysis resulting in malabsorption, which cause depletion of vitamin A, causing night blindness and altered gene expression. Next question देखो बेटा, storage and mobilization of liver, retinal esters and stellate cells, then acted by retinal ester hydrolase and then conjugated with RBPs. After that biochemical management. 3 है, ऐसे करना. Next case बेटा लिखो ये सब. Please note this case down and read it 2 to 3 times thoroughly. Do not make any diagnosis without thoroughly reading the case. कैसे पता चला? मसल वीकनेस और किसी में नहीं हो सकती. सीरम कैल्शियम इज नॉट लो, इट इज नॉट मच लो. इट इज अ केस ऑफ विटामिन डी डेफिशिएंसी. विटामिन डी डेफिशिएंसी. क्वेश्चंस लिखो बेटा. It has some details and vivid questions. Please note it down. What is the most likely biochemical diagnosis of this patient? After that, explain the biochemical pathway of vitamin D synthesis and its regulation. How does vitamin D deficiency leads to changes in calcium, phosphate and ALP levels? What is the role of 1-alpha hydroxylase? And vitamin D metabolism and how it is regulated. Why do patients with vitamin D deficiency develop muscle weakness and bone pain at a molecular level? At molecular level. How does PTH compensate for vitamin D deficiency? And what are its effects on calcium homeostasis? Explain the role of vitamin D receptor in gene expression and calcium absorption. And after that, what are the biochemical markers that differentiate vitamin D deficiency from primary hyperthyroidism? Do not just note down immediately. एक एक लाइन को अच्छे से समझिए, खुद से समझिए और तब लिखिए. विटामिन डी की क्लास हो गई ना बेटा? ई और के भी खत्म हो गया ना? हो गया ना? Vitamins, everything is complete except I think vitamin C is left. हाँ तुम तो एब्सेंट थे. विटामिन सी रह रहा है ना अभी? ठीक है. Vitamin C is left. How does PTH compensate for vitamin D deficiency? What are its effects on calcium homeostasis? Questions पढ़ो बेटा सारे एक बार और. Answers देखते हैं बेटा. Most likely biochemical diagnosis. The patient has vitamin D deficiency indicated by low 25 hydroxy vitamin D, hypocalcemia, hypophosphatemia, and increased ALP. Hypocalcemia, hypophosphatemia, and increased ALP. These findings suggest secondary hyperparathyroidism due to vitamin D deficiency. These findings suggest secondary hyperparathyroidism due to increased vitamin D deficiency. Okay, 25 hydroxy vitamin D. Okay, low 25 hydroxy vitamin D. Then आगे देखते हैं biochemical pathway of vitamin D synthesis and its regulation. Synthesis और regulation दोनों. Step 1 skin. Step 1 क्या है? Skin. UVB dependent synthesis. UV dependent synthesis. बेटा are you all right? ठीक हो? पानी वानी कुछ. 7-dehydrocholesterol precursor in the skin. Then it converts into pre-vitamin D3 by UV light. After that, this pre-vitamin D3 is converted into vitamin D3 spontaneous thermal isomerization. Step 2 liver. Step 2 is in liver. Hydroxylation by CYP2R1. Cholecalciferol converted into 25 hydroxy vitamin D calcidiol by 25 hydroxylase. Then 25 hydroxy vitamin D is the major circulating form. Half-life somewhere around 3 weeks. Step 3 kidney. Hydroxylation by CYP27B1 activated by PTH. 25 hydroxy vitamin D. 125 hydroxy vitamin D calcitriol active form. By alpha 1 hydroxylase CYP27B1. Step 4 target organs and actions. Intestine. Calcium and phosphate absorption बढ़ा. ठीक है. Via TRPV6 calbindin D sodium phosphatase 2B transporter. ठीक है. Bone. Osteoblast activation. Osteoclast differentiation via RANKL expression. Then kidney. Calcium excretion, phosphate excretion. एक घट रहा है, दूसरा बढ़ रहा है. ठीक है. Regulation. PTH increases alpha 1 hydroxylase, increasing calcitriol. Okay. Then FGF23 decreases alpha 1 hydroxylase, which decreases calcitriol. After that, high calcium and phosphate inhibit alpha 1 hydroxylase. Net effect being decrease in chlocalciferol and calcitriol. ओके. एक बार इसे अच्छे से बेटा लिखो. ओके. You should write down these things. Some are very complex terms बेटा. इसको लिखो, अच्छे से याद करो. This is an important topic. Step 1 is in skin. Step 2 is in liver. Then step 3 kidney. Step 4 target organs, and then its regulation. That is due to action of PTH बेटा. PTH acts in this way. क्योंकि PTH एक अलग रिसेप्टर पे बेटा इंटेस्टाइन में काम करता है और एक अलग रिसेप्टर पे बेटा दूसरी जगह काम करता है. दैट इज किडनी. हाँ, इसीलिए वहां पे दोनों जगह पे बेटा एक्शन सेम ही रहेगा. इसीलिए तुम्हें ये दिख रहा है. Because phosphate is coming from multiple sources. PTH is not acting on intestine and kidney, beta, it is acting on bone also. It is releasing phosphate from there. इसीलिए दोनों जगह से उसको निकालना है. अगर नहीं निकलेगा क्या होगा बेटा? गॉल स्टोन्स, किडनी स्टोन्स. प्लीज रिमेंबर दिस रेगुलेशन बेटा केयरफुल. ठीक है? Changes in calcium, phosphate and ALP. Biochemical changes in calcium, phosphate and ALP. Low serum calcium. Intestinal calcium absorption low due to low 1,25 dihydroxy vitamin D. 1,25 dihydroxy vitamin D. Okay. Low serum phosphate. PTH induced phosphaturia due to secondary hyperparathyroidism. Okay. PTH induced phosphaturia due to secondary hyperparathyroidism. And after that beta high ALP बढ़ा हुआ क्यों? उसका रीजन increased bone turnover, reflecting osteoid accumulation and defective mineralization, osteomalacia. Okay. 3 रीजंस है बेटा जो इस केस में बायोकेमिकल रीजंस हैं. फर्स्ट वन इज लो सीरम कैल्शियम, देन लो फॉस्फेट, देन हाई ALP. तीनों के रीजंस बेटा लिखे हुए हैं सामने. Low intestinal calcium absorption due to low 1,25 dihydroxy vitamin D. Then low serum phosphate, PTH induced phosphaturia due to secondary hyperparathyroidism. And then high ALP, increased bone turnover causing osteomalacia. The role and regulation of alpha-1 hydroxylase. Role and regulation of alpha-1 hydroxylase located in proximal tubules of kidney. Converts 25 monohydroxy vitamin D to 1,25 dihydroxy vitamin D, which is active form. Converts monohydroxy form to dihydroxy, indicating activation of vitamin D. Actually, this is also not the active form. It will convert it further. Stimulated by PTH in response to hypocalcemia. In case of hypocalcemia, beta, PTH would be secreted, activating its conversion. After that, low phosphate, inhibited by high 1,25 dihydroxy vitamin D, which is controlled by negative feedback. And then FGF23 secreted by osteocytes in response to high phosphate. All of this is regulated by alpha-1 hydroxylase, the enzyme alpha-1 hydroxylase, located in PCT. Done? लिखिए बेटा, लिखिए, इसे जल्दी लिखिए. Stimulated by secretion of PTH, hypocalcemia, and low phosphate level in serum or blood. Then inhibited by high 1,25 dihydroxy vitamin D under the control of negative feedback, the homeostatic feedback. Then FGF23 from osteocytes in response to high phosphate, which is in complete conjugation with 0.1. Okay. चलिए बेटा आगे देखते हैं. Molecular basis of muscle weakness and bone pain. Molecular basis of muscle weakness and bone pain. Vitamin D deficiency, which is low 1,25 dihydroxyvitamin D. A deficiency of 125 dihydroxyvitamin D. Low 125 dihydroxyvitamin D decreases expression of cal-binding D in muscles. Cal-binding का बेटा expression रुक गया. Then impaired calcium homeostasis in muscle fibers, reduced excitation, contraction, coupling. Okay. After that, bone pain, unmineralized osteoid accumulation causes microfractures, osteomalacia. So first one is beta vitamin D deficiency, and second impaired calcium homeostasis. Third is osteomalacia causing microfractures. PTH compensation and its effect on calcium homeostasis. Okay. Low vitamin D, it causes hypocalcemia. Hypocalcemia, increased PTH secretion. Secondary hyperparathyroidism. Okay. Secondary hyperparathyroidism. Effects of PTH: renal calcium reabsorption, osteoclast activation, and alpha-1 hydroxylase activity. Increasing absorption and synthesis of 125 dihydroxyvitamin D. All of which are triggered by increased PTH secretion. First one is renal calcium reabsorption, and second osteoclast activation, and then third is alpha-1 hydroxylase activity. All are increasing. Next, role of vitamin D receptors VDR in gene expression. VDR is a nuclear receptor, ligand dependent transcription factor. It is a transcription factor which is ligand dependent. Activated VDR forms a heterodimer with retinoid X receptor. Binds vitamin D response elements in target genes. Binds vitamin D response elements in target genes. Regulates TRPV6, cal binding, and RANKL, osteoclast activation for bone reabsorption. Okay. So this is how gene expression is regulated. The role of vitamin D receptors in gene expression. So these are the major gene expression mechanism of vitamin D. First one is activated VDR forms a heterodimer with retinoid X receptor. Then in target genes, it expresses cal binding D and osteoclast activation. ये है बेटा, ये important है. Vitamin D deficiency and primary hyperparathyroidism. How will you differentiate vitamin D deficiency and primary hyperparathyroidism? Serum calcium. In vitamin D deficiency, it is normal or decreased. In primary hyperparathyroidism, increased. Serum phosphate, low in both. PTH, increased in both. 25 monohydroxyvitamin D, decreased, or it is normal or low. Not a definitive marker. Then 125 dihydroxyvitamin D, decreased in vitamin D deficiency, normal or high in primary parathyroidism. Once again, not a definitive marker. Then ALP, increased in both, or it can be normal in some cases, and primary hyperthyroidism. So this is how we make differential diagnosis in vitamin D deficiency and primary parahyperthyroidism. These are the markers for differential diagnosis, since both of them have overlapping symptoms, causing confusion. Until and unless differential diagnosis is not established, we cannot start the treatment in the concerned direction. So these are the few markers, the biochemical markers, A and D, vitamin A and vitamin D. Now, a 28-week preterm neonate presents with jaundice, pallor and anemia. Laboratory test reveals elevated reticulocyte count, low hemoglobin and increased erythrocyte osmotic fragility. The physician suspects vitamin E deficiency. What would be your probable diagnosis? Elevated reticulocyte count, low hemoglobin and increased erythrocyte osmotic fragility. Based on this, please read the case 2 to 3 times and make a provisional diagnosis out of this. Read it carefully and justify your answer. Without justification, no answer would be accepted. सेल मेम्ब्रेन को तो बेटा 500 और चीज़ भी मेंटेन करती है, आपने उनकी डेफिशिएंसी तो नहीं बोला. एंड विच सेल मेम्ब्रेन बेटा? RBCs. There are a number of other factors that can influence cell membrane integrity. Then why only vitamin E? My question is this बेटा. आगे तो मैंने लिखा बेटा, the physician suspect vitamin E deficiency. In real world, in real life बेटा, you have to suspect what is the case there. वहाँ लिखा नहीं मिलेगा आपको कि physician ने ये suspicion भेजा. चलो देखते हैं. What is the biochemical basis of vitamin E role in red blood cell integrity? First question. Second, why are preterm neonates particularly susceptible to vitamin E deficiency? Vitamin E deficiency. After that, how does vitamin E deficiency lead to hemolytic anemia? Leads to hemolytic anemia. What biochemical test can confirm vitamin E deficiency in neonates? How does vitamin E interact with glutathione and other antioxidants in RBC production? Okay, these are the things. Now let's discuss one by one. बेटा आपको आपका आंसर मिलेगा भी देखिए. Now, biochemical basis of RBC protection. Biochemical basis of RBC protection. RBC membranes contain PUFA. ठीक है? I hope everyone is familiar with this term. Which are prone to oxidative stress. सबको पता है ना बेटा PUFA क्या होता है? सुना है ना? बस बढ़िया, आप तो जानते हैं सब. Which are prone to oxidative stress. Vitamin E prevents oxidation of these lipids, maintaining membrane stability and preventing hemolysis. Okay, so this is the reason. Second, susceptibility in preterm neonates. Susceptibility in preterm neonates. इसको लिखते रहिए सर. Limited placental transfer of vitamin E. This is causing vitamin E deficiency in preterm neonates especially, as it occurs mostly in third trimester. Okay. Low hepatic store and reduced alpha TTP activity. Okay, alpha TTP activity. High oxygen exposure in neonatal high oxygen exposure in neonatal intensive care units, increasing oxidative stress. In an ICU, we administer oxygen to the neonates that increase free radical generation, because that oxygen is of very high grade purity. कभी कभी होता ना, बहुत अच्छी चीज़ भी आदमी को खराब कर देती है. That's happening here. Generating high amount of free radicals. Okay. First one is, what is the biochemical basis of RBC protection? And then second one is susceptibility in preterm neonates. Then mechanism of hemolysis. What is the mechanism of hemolysis? Oxidative stress leads to lipid peroxidation in RBC membranes, causing fragility and rupture. लिखिए इसे. Please write down each and everything which is written over here. In deficiency of vitamin E, what is happening? There is oxidative stress causing hemolysis, peroxidation of PUFAs, which is maintaining the membrane integrity. Damage by free radicals, and that is why there is hemolysis. As a result, what is happening? Intravascular hemolysis causing anemia and increased bilirubin levels. So this is the mechanism of hemolysis. Okay, समझ आया? This is the mechanism of hemolysis. Then, what is the diagnostic biochemical test? Diagnostic biochemical test for this case. Serum vitamin E levels less than 3 mg per liter. Less than 3 mg per liter. In neonates indicates deficiency. So this is a parameter for deficiency in neonates. Then erythrocyte hemolysis test. Excessive hemolysis when exposed to hydrogen peroxide. Causing excessive hemolysis under the influence of hydrogen peroxide is one more common test done in pediatrics department to assess vitamin E levels roughly. Okay? Erythrocyte hemolysis test. Remember, okay? Using hydrogen peroxide. After that, increase serum malonaldehyde as an indicator of lipid peroxidation. In short, MDA, which is one more clinical sign for lipid peroxidation. Okay? This test is also done. These are all biochemical tests. Then, interaction with glutathione and other antioxidants. Vitamin E stabilizes membranes. While glutathione peroxidase neutralizes hydrogen peroxide. Okay? Then, synergistic action with vitamin C, which regenerates oxidized vitamin E. Once oxidized, vitamin C helps in regenerating it, indicating a synergy in action of both vitamins. Okay? What is your provisional diagnosis and why? Theory में भी पढ़ा है vitamin E और एक clinical case देख के आ रहे हो. Explain it. सब चीज़ का आंसर PPT से नहीं देखो. Try to explain something in your own words also. I do not want just one answer. I want the explanation. Receptors होता ना बेटा, वो वाला डिपार्टमेंट बताएगा. फिजियो कहाँ पे कितने होते हैं, लाइक पीठ पे जल्दी कुछ फील नहीं होता. Why? That's all part of clinical examination. बट सिंस दिस जस्ट अ क्लिनिकल साइन बेटा, तो इसलिए यहाँ पे लिखना पड़ता है ताकि एक ना एक दिन प्रोप्रियोरिसेप्शन पढ़ो तो यहाँ से रिलेट तो हो बेटा. ठीक है? व्हाट इज द प्रोविजनल डायग्नोसिस एंड व्हाई? प्लीज एक्सप्लेन. हु इज गोना ट्राई? द क्वेश्चन इज ओपन टू एवरीवन except Sharik and Adil. A 35-year-old male with a history of chronic fat malabsorption. Secondary to cystic fibrosis, presents with progressive difficulty in walking, loss of proprioception and absent deep tendon reflexes. Okay. Neurological examination reveals ataxia, dysarthria and a positive Romberg sign. Positive Romberg sign. First question. What is the biochemical role of vitamin E in neuronal function and how does its deficiency leads to neurological defects? Questions likhe beta sir. Has everyone written those questions? Question 2. Describe the mechanism by which vitamin E prevents oxidative damage in cellular membranes. Question 3. How does vitamin E deficiency affect lipid peroxidation and what are its implications in neurological degeneration? Neurological degeneration. What biochemical markers can be used to diagnose vitamin E deficiency? And question 5. How does the role of alpha tocopherol transfer protein influence vitamin E bioavailability and what are the implications in ataxia with vitamin E deficiency? Okay, so these are the investigations we need to do. चलिए देखते हैं biochemical role in neuronal functions. Vitamin E, primarily alpha tocopherol, acts as lipid soluble antioxidant. Okay, protecting neuronal membrane rich in polyunsaturated fatty acid from oxidative damage. अभी पीछे देखा है, दोबारा भी आ गया. Its deficiency leads to increased oxidative stress, damaging neuronal myelin sheath, causing demyelination and axonal degeneration, leading to neurological symptoms. ठीक है, तो इस वजह से डैमेज हो रहा है. Then mechanism of oxidative production. Vitamin E donates an electron to reactive oxygen species. Okay, you all know what are reactive oxygen species. Neutralizing lipid peroxyl radicals in membrane. This prevents the chain reaction of lipid peroxidation and maintain membrane integrity. The oxidized tocopherol radical is regenerated by vitamin C or glutathione. Once captured, it is regenerated by vitamin C or glutathione, whatever is available. Now, effect on lipid peroxidation and neurological implication. प्लीज़ लिखते रहिए सर, खाली मत बैठिए. जो चीज़ आपको समझ में, जो चीज़ याद है, जो चीज़ आपको समझ में आ रही है बेटा वो समझ लो, जो नहीं समझ में आ रहा तो लिख लो. मेरा मानो तो पूरा ही लिख लो. Now, effect on lipid peroxidation and neurological implications. Vitamin E deficiency leads to increased lipid peroxidation due to unchecked free radical damage. Accumulation of lipid peroxide disrupts neuronal cell membrane integrity and myelin sheath function, resulting in अरे तो हो गया था ना. अच्छा, resulting in axonal degeneration and demyelination seen in posterior column degeneration. Now, biochemical markers for diagnosis. What are the biochemical markers for diagnosis? Serum alpha tocopherol levels less than 5 mg per liter suggest deficiency. Erythrocyte hemolysis test. Increased hemolysis in response to oxidative stress. This test is come once again बेटा, पहले भी था अब दोबारा है. ठीक है, it's the same test जो हम NICU में कर रहे थे वो यहाँ भी कर रहे हैं. Serum MDA levels, malonyl aldehyde elevated and increased lipid peroxidation.
सर इसमें जो मतलब बनने के बाद डिग्रेड करता है, बनने के बाद और एक मिनट में बनता है.
किसमें? वहाँ पे भी डैमेज होता बेटा, वहाँ पे भी डैमेज होता है. देयर द डैमेज इज नॉट इन माइलिन शीथ बेटा, देयर द डैमेज इज ड्यू टू लैक ऑफ ग्लूकोज मेटाबॉलिज्म. थायमिन बेटा किस में काम आता है? ग्लूकोज मेटाबॉलिज्म में. हाँ, यू कैन से TPP. वहाँ पे बेटा माइलिन पे इतना डैमेज नहीं हो रहा जितना सेल में खुद में डैमेज हो रहा है बेटा. सेल इज लिटरली स्टार्विंग एंड सेल एज अ होल इज डीजेनरेटेड. When a single cell degenerates beta, it initiates a chain reaction खाली एक सेल थोड़ी स्टार्व करेगा बेटा, एंड एज अ रिजल्ट दैट होल थिंग इज डिजेनरेटिव. The first and the most effect is seen in the most metabolically active cell in your vital centers. So these two are different things. इसे उससे रिलेट मत करो. एरिथ्रोसाइट hemolysis test, ठीक है, to assess vitamin E activity. Then serum malonyl levels, MDA levels, elevated in increased lipid peroxidation. Then plasma vitamin E to total lipid ratio less than 0.8 mg per gram indicates deficiency. Okay? तो बेटा ये इसके बायोकेमिकल मार्कर्स होता है डायग्नोसिस के. ठीक है. Role of alpha TTP in bioavailability and implications in ABED. Function. Alpha TTP facilitates hepatic secretion of alpha tocopherol into plasma. Alpha TTP facilitates hepatic secretion of alpha tocopherol into plasma. Okay. Then ABED pathophysiology. Mutations in TTPA gene impairs alpha TTP functions, reducing vitamin E transport to tissues, towards tissues, particularly neurons, leading to progressive ataxia and neurodegeneration. Okay, in ABED. Now, I think this is the last case for today. A 55-year-old male with cirrhosis presents with easy bruising, melena, and prolonged bleeding after minor trauma. Minor trauma. Laboratory findings show prolonged PT and INR, normal platelet count, and low serum albumin. Low serum albumin. What do you think is the provisional diagnosis of this patient? Yes. Now let us see. Explain how liver disease contribute to vitamin K deficiency leading related bleeding. How can you biochemically differentiate vitamin K deficiency from disseminated intravascular coagulation? Which laboratory test can confirm vitamin K deficiency as the cause of coagulopathy? After that, why is factor 7 affected first in vitamin K deficiency? Okay. And the last question is, what are the treatment options for vitamin K deficiency in this patient and how do they work biochemical? ठीक है, चलो एक एक करके देखते हैं. Liver diseases and vitamin K deficiency. Liver diseases and vitamin K deficiency. सबसे पहले देखो बेटा, the liver synthesizes vitamin K dependent clotting factors. Okay. In cirrhosis, decreased hepatic function leads to reduced production of these factors. Reduced production of these factors. Additionally, biliary obstruction due to liver diseases impairs fat-soluble vitamin absorption, worsening the deficiency. Okay, simple. Differentiation from DIC, vitamin K deficiency, beta, prolonged PT and INR. Okay, then normal fibrinogen levels and normal platelet count. Normal fibrinogen levels and normal platelet levels. DIC में क्या होता है बेटा? Prolonged PT and APTT. Low fibrinogen and thrombocytopenia due to excessive clotting and fibrinolysis. Presence of D-dimer and fibrinogen degradation products. Okay, D-dimers and fibrinogen breakdown products. लिखते रहो बेटा, ये डायग्नोसिस में बहुत काम आता है. These are very instrumental in diagnosis. Then diagnostic test for vitamin K deficiency. Factor assay, reduced activity of vitamin K dependent factors 2, 7, 9 and 10 confirms the deficiency. 2, 7, 9, 10. Rapid PT correction after vitamin K administration suggests deficiency as the cause. So there are two biochemical tests, 2, 7, 9, 10 and second vitamin K administration related correction in PT times. PT है ना? PT. So these are the two biochemical parameters. Done? Next slide. Factor 7 sensitivity to vitamin K deficiency. ठीक है? Factor 7 has the shortest half-life, 4 to 6 hours, among vitamin K dependent factors. Okay? Affected first, leading to prolonged PTINR before APTT becomes abnormal. All are terms well versed used in hematology. ठीक है? सब टर्म्स आप लोगों को अच्छे से पता होने चाहिए बेटा, हिमैट में बार बार यूज होते हैं. ट्रीटमेंट ऑप्शंस इन बायोकेमिस्ट्री. Vitamin K1. Vitamin K1 restores gamma carboxylation of clotting factors. ठीक है? Then fresh frozen plasma FFP provides ready to use clotting factors. Ready to use clotting factors. Then prothrombin complex concentrate PCC rapidly corrects INR in life threatening bleeding. Okay? So these are the treatment options. These are your treatment options. So this ends with today's class, beta.